Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, welcome. It's great to have you here. We're super excited because we're having some just honestly fantastic conversations with real leaders that are painstakingly reshaping the future of healthcare. And we're just crazy passionate about a few different things. We're passionate about healthcare innovation, about access, about adoption of these innovations, and leadership. And if it's your first time tuning in, let me just take a quick step back and give you a little bit more of the lowdown of what we're really trying to get done here. So, we're focused on bringing real stories of innovation and leadership to life. Not just stuff that you hear and read in headlines, but like the real stuff, the little wins, the learnings, and the aim is to highlight these folks that are truly innovating and leading in an incredibly difficult time. And we want to share that with our community and ultimately bring their story to the world. We've got an amazing action-packed year. If you haven't checked out any of the historical interviews, however you're consuming this, if you're watching it, if you're listening to it, please hit the subscribe button now so that any of the new episodes come directly to you. Really excited about today's guest. Our next guest is Mike McCabe, CEO of On Advisors. So Mike has spent his career inside of health plans, not around them, inside them. He's been in the rooms where hard calls get made, the ones that don't show up in press releases, the ones that affect patients, they affect doctors, they affect entire communities. So Mike has been a seasoned healthcare health plan executive, and he really kind of understands how strategy turns into action or doesn't. So he's worked across growth, operations, transformation as a CIO, and he has seen firsthand how good intentions can fall apart once incentives get messy. So what I appreciate about Mike is he doesn't just talk in buzzwords and jargon, like he actually tells you what actually happens, where things break, where trust erodes, and where health plans have a chance, a real chance to do better, and sometimes don't. So this conversation isn't going to be about who's right, who's wrong. It's about what happens when health plans are under pressure to deliver. What are some of the things that we can do, moving ahead in the future to continue to innovate and continue to drive and add value? Maybe what they struggle to say out loud and what's got to change if we want a system of people that can actually understand and start believing and having trust back again. So if you work in healthcare, and especially if you are looking at putting solutions into these types of entities, um, you're gonna really enjoy this conversation. So Mike, great to see you. Welcome to the show.
Thanks for having me on. I'm excited. I've been actively reviewing and seeing a lot of your cast, and it's really good. And I like the DNA and what you're doing. And I couldn't thank you enough for inviting me, and looking forward to a conversation.
Awesome. Well, thank you for those kind words. But before we kind of get into, titles and org charts, where did you grow up? What kind of kid were you?
I played a lot of sports. Very large family, very underserved. We grew up very poor,
Mm,
and that probably through my career gave me that passion for underserved communities, safety nets, critical access,
mm,
really understanding the population, and didn't even know it.
mm.
I had a great, and I went into the military, which paid for my college, and that was the route. And had a lot of fun, and I enjoy what I do, and I'm uh, guilty of being passionate around the delivery system, and I always love a good conversation around healthcare.
Right on. I mean, who was outside of your parents, maybe who was sort of the first adult or professional in your life that made you feel like, hey, you've got something here, you've got potential?
Well, I'd say, I have a lot of mentors through my career, and Jim Donovan is probably the greatest mentor and influencer that I worked with to the delivery system, and did the transition from technology to business development, and it's a tough transition, and I can't think of anybody that's really done that to be an expert in the business side.
Mm,
But I could name a few off the list:
okay.
Bill Hagan, John Kalin, Blaine Bergeson, working with a lot of industry experts that have said, yeah, it's okay. You can transition from technology. Technology comes to me very easy, and that's a lot of the struggle within the business leadership or executive
Mm,
leadership is connecting that. Well, I do that very well. And so when I see something that's presented, I'm looking at the business impact based on the technology capabilities, and I can usually tell you sooner than later whether or not you need to cut and run or to be able to deliver. And that's been an area of expertise that's resulted in billions of dollars of revenue in strategic growth for a lot of health plans around the country. So.
what's maybe like a moment early in your career where you realized this this system is way more complicated than people think.
I spent a lot of time in and out of capitals around the country, been in over 30
Mm,
states, pushing different policy and understanding how the delivery system actually transforms for payers and providers. And I've driven 3 hours to meet with a single provider in northeastern Washington just to talk healthcare. And
mm,
so I think it's been a transition over many years in meeting with thousands of providers and representing several large payers and small payers, being able to understand the delivery system and understanding healthcare is local. And there's a lot of socioeconomic drivers that influence a lot of these buzzwords that you hear:
right, right.
PMH, value-based payment, at risk. And the definitions vary from state to state and policy to policy and waiver to waiver. There's a sense of consistency, but you know, through the years, I've been able to, forge through and have a very good understanding of the delivery system uh, along the
Hmm.
way.
So when things go sideways, and they do go sideways sometimes, where do they actually break first? Where like no one really talks about it.
But they're afraid to talk about it. They're afraid to engage on it because of they don't want people to know of some stress points, competition wise, and especially if they're publicly traded, they want to keep it confidential. The stress points are usually the network. I mean, insurance companies, what they do is build networks. That's what they do.
Mm,
And sometimes they're not built to the level they need to because the providers are trying to get the most money they can. But there's three areas that you have to harmonize within a health plan if you're at risk or want to go to risk. The claim adjudication system has to be configured appropriately to pay per the contracts.
mm,
And they have to both complement the clinical model that you've deployed. If you've deployed an outdated clinical model, you're not going to get the optimal outcome that you would like relative to your medical loss and your admin loads. So these three focused areas have to work together in order to get you the MLR of what you need and the administrative load you need for a foundational growth element. I mean, you need to grow or you're going out of business. So you should
right.
always be looking at growing and optimizing where you're at. And some of these systems are running on health systems, and payers are running on systems that are 10, 15 years old and haven't upgraded them. And those are usually where you fall because policy is updated sometimes 2 or 3 times a year. And you have to stay up to speed with the capabilities that are out there and take better use, do more with less. I mean, AI
Mm.
is great, but AI you have to check and validate. Can't just go, oh, I got AI, AI, the world's coming to an end, because I think a lot of people are starting to realize AI is good, but you need a process to check and manage and monitor.
So what are some of those things that you know that listen, the only thing that's constant is change. Are there certain things that you know aren't going to be changing that you like to keep an eye on and say, hey, these are the elements that we need. It sounds like, building and maintaining and growing a strong network, optimizing for that, that's important. What what else is there that's not changing that you're oftentimes drifting from? Because I think when you and I spoke earlier, and we're talking about this drift that's happening. It's like, hey, we need to kind of get back to basics. What are some of those basic things that are often overlooked because there's shiny object syndrome over here, and let's go and tweak the dials on that. But like, what really, truly, actually matters?
Population health management, getting clinicians to work at the top of the scale. We burden them down with a lot of administrative tasks that we shouldn't. Um, Things like correct coding is sometimes overlooked. Sometimes the UM seems to be on automatic pilot and maybe doesn't have the due diligence it should. So better use of community health workers and care navigators, programs that safety nets have been doing for quite some time need to probably be front and center in the delivery system to allow those licensed individuals to work at the top of their license. It's
Mm,
no surprise that primary care, there's not a lot of primary care and they're aging out of the population. There's a lot of studies that are out right now talking of how primary care is really limited, but our population is growing and there's a lot of individuals that are aging. So there's not enough infrastructure to support the members that are there. And the members are always going to be there. And what's going to happen is they're going to go to the ER, and that's may not be the best place to get care. We want to push individuals to primary care. That's where the best care can be managed by a primary care physician in the office and the best preventive care that can be done. But unfortunately, because of the limitation in primary care nationally,
right.
individuals are going to the ER, and that's having an adverse effect, running up the cost. Because what happens when you go to the ER? They're going to do an
Mm,
MRI, they're going to do this lab, they're going to do X, Y, and Z, and that's how your cost starts racing. So you need a very effective program and understanding of the nurse line, MD Live, primary care, and even incentives. If you're building a product, if it's a commercial product, incentivize the employees on the appropriate use of the ER and maybe put a copay or something. So
you just unpacked a lot there, and I want to just kind of break things down a little bit more deeper. When you're talking about clinicians working at top of license and removing some of the administrative burden, does that fall on the provider to be able to do that to create more efficiencies, or does that fall on the payer to be able to kind of collaborate, with the provider to be able to do that? And kind of just to add on to that is like, listen, you've built networks all over the United States. What is that relationship like, truly, when you're building networks?
between hospitals and payers, it's pretty tough. Those negotiations are very different, but it should be collaborative in many aspects because there's always going to be bodies for the beds and heads in the beds, but it's a different philosophy. Insurance companies are trying to reduce ER and heads in beds, and then the providers are over here trying to increase and have record numbers. But in order to address it, they have to work together, and that's where value-based payments are a big influencer in the ability to work together. So if your incentives are aligned, you can get to that happy spot as far as a balanced delivery system. But it has to be a joint effort in order to address that. It has to be. We usually look, the team that I work with, we usually look for CINs or primary care associations or IPAs that are physician based for value based payments. And in those programs, the money that's discussed that they don't talk about actually comes from the hospitals. And that's why it's very difficult with
In
a
the
health system
hospitals?
to get all the money's in the inpatient and the hospitals. I mean, that's where the majority of the cost is. And is that so when we go out and we look and we build a network and we do a value-based payment, we're doing those total cost of care, some of those value-based payments were way more effective with primary care practices in executing. Uh, and if I go out and I've met with hundreds of FQHCs, we put in value-based payments on readmits and appropriate use and making sure we're reducing those acute events. In fact, we just deployed a population health stratification model for high risk members with a client, and we're saving about
Right.
1.5 million a month. And it's
Wow.
if it's not done, you're basically fee for service. You want to move to the rigor of managed care and population health with that member centric model. It's easy to do with technology, but what you see out there is a lot of vendors that are selling, oh, yeah, we do this. They don't really do this. And so there's solution sets that are out there. Just be careful when you're selecting the solution set that you check the references. You get experts to come in and say, yeah, this is what it's going to be like. And don't kid yourself. You gotta spend the money to get the money. So
Hmm. Well, I mean, look, you're always learning lessons, and I'll call them. There's probably been some of the expensive experiences that have happened in your career. Maybe you didn't fully realize those until years later. Are there any that you look back fondly on? You're just like, oh man, big lesson learned there. And if so, what any stories come to mind that you're willing to share?
Uh, boy, I've been there's been a couple. The negotiations that take place with building a network are you have to get them actuarially set and verified. That's very important when you agree to a rate to understand the discharge volumes and the DNA of the cohorts that you're treating.
Mm,
Adverse selection happens, and so there are capabilities to understand the acuity level of a population and if your actuaries is telling you that these rates aren't going to work, don't bid on it. Don't chase that business or you're going to lose money. Because sales is wanting to push, but you got to have profitable growth. And there's
mm,
been scenarios in the past where we wanted to win the business because it influenced the stock market, and we want to be able to put there, hey, we won, 4,000 new lives or 100,000 new lives because the stock market reaction, but at the end of the day, it was not profitable growth. And
mm.
you really need to have the due diligence in balancing sales and growth and actuaries to make sure that it's profitable growth. And I think everybody can relate to that. There's always contention in the plan. We need to grow because the salesperson has growth goals and, finance, and we have a P&L to manage at the same time.
You mentioned around just networks. I want to kind of drill on that, but what's one word you would use to describe provider relationships today?
One word. Oh boy, I could get in trouble for this one. It's a cantankerous relationship. It really is.
Wow, that's a good SAT word, cantankerous. Wow.
It's uh, I enjoy safety nets in rural areas are always welcome and always looking, and they get it. They want to diversify their product lines and have multiple streams. So you have the ebb and flow of healthcare. You're always
Right.
going to have different political positions and policies coming out. But if you don't diversify your portfolio and diversify your contracts, you're not going to be able to make it through those waves. And so when there's an event, you're going to feel it more. So you definitely need to diversify your products, look to go at risk if you can. And I enjoy the safety net side of what I do a lot, but the large health systems that are inner city, they have a very meaningful purpose in the services they and expertise and specialists they provide too. But
Wow. You know, I'm just sort of thinking because there's a lot of misunderstood things about health plans. What do you think is the most misunderstood thing that people get wrong about health
make
plans?
a lot of money. The margins in health plans are very small, and based on their contract that they've been able to negotiate in the provider, that's the rate. So it's
Mm,
not like the payers are over there just saying, "Oh, this is what we're going to charge and this is what we're going to do." It's defined on how efficient of a network they can build, and sometimes they can't build an efficient network. So I think there's a little bit of love on both sides. The
mm,
charge master, scenarios with hospitals is always interesting and a whole nother discussion on how those are developed, but and the lesser of language in contracts. But
mm.
I think there's a little bit of a misunderstanding. I hear politicians saying, "Oh, the insurance companies are making all that money," but that they don't have an understanding of the delivery system and when you start pulling back benefits and pulling back activity relative to Medicaid or, the
Right.
exchange,
Right.
They can go to the ER anytime. And this happened in the late 90s, early 2000s, where they didn't have coverage. What happened? Our ER skyrocketed in the cost. And that's not the best care that we can provide. So I think there's, a level handed that needs to be looked at. I think there's a duplication of administration between Medicare and Medicaid. I'm not a Medicare for all person. I'm just saying there's administrative simplification because there's overlap in
Right.
process and technology and administrative policy between Medicare and Medicaid and even exchange.
Mm.
So there's some efficiencies to be gained, but the payers are heavily regulated, just like
Yeah.
systems are too. But I don't think that there's love to go around that arena,
Yeah.
not just all the
Yeah.
insurance company.
I mean, just given that you've seen different seasons, you've seen a lot. Are there patterns that you see that are emerging, and what ones are reemerging that you're seeing now that you're like, oh, kind of seen this before? Any insights that you can kind of share there?
No, to me, it's a lot of the basics. I think providers are going to bill and optimize their billing as much as they can, given the market dynamics and the responsibilities of the payers to make sure that they have the appropriate billing per the contract. I think that's been going on. I think there's higher use of some pharmaceuticals that
Mm.
have come up before that. I think we had the Hep C drug before. Now it's Ozempic, where it seems like there's always going to be an ebb and flow of some type of control that you need to put in, or options or evidence-based step therapy in the process. But it seems like something always comes up that's going to drive and put stress on the MLR. But you have to have the reporting and the tools in play to be able to respond timely and action timely when you see that event. If you're monitoring, if you're not monitoring or you're monitoring and have a latency, you really need to monitor week to week, month to month, and know your key indicators and proactively manage, especially if you have TPAs.
Mm.
If when a TPA is watching out for your best interest, that may not be the case. Your TPA is only as good as your contract and how much oversight you've provided to that contract to that TPA. So that's really
Interesting.
important. Yeah.
I mean, but what's something that health plans say they want, but maybe their behavior says they don't?
I think that's a good question. I think almost all of them want population health management and individuals to live a better quality of life. I don't think there's
Yeah.
a payer out there that doesn't want that. But from a regulatory standpoint and an audit standpoint, they need to make sure that coding and billing is consistent and correct because they get audited on a regular basis, and there's rules to live by. I think there's a rumor that, well, they just deny because they deny. No, they have rules that they need to follow per the contract and the denials. That's why they have a prior authorization list. You need to make sure you're following that. And they have benefit configuration and benefit design that need to be adhered to.
Mm.
So I think all of them really want to help individuals and do, member-centric care and be as responsive as possible. But with the financial pressure, you lose a lot of staff, and there's rifts, reduction in force in areas where sometimes accidentally a core competency walks out the door and there's an unknown. There's a lot of volume that has to be managed, and it's a lot to monitor. And
Hmm.
sometimes you know, things happen where there's a code update that nobody knew about that all of a sudden this is denying. It isn't intentional. It's insurance companies have technology systems that they update code to. So do
Right.
health systems. They have inadvertent billing because they did an upgrade and all of a sudden they're billing for, certain procedures where they weren't allowed to in the past. So a lot of it is unintentional, but because the technology is so complex, you got to stay on top of it or you're going to have people are going to assume, well, that was intentional. That may not have been the case. So pick up the phone
Right.
and talk to somebody.
If you can get to someone, it's
You
hard to
always
call an
should know
insurance
the
company, call someone.
you should
Yeah.
always know the leadership of every group that in your communities that you're working with should always to be able to pick up the phone. So in most all the environments that I was in, we had direct contact with the CEOs, COOs, CMOs, and have monthly meetings, a lot of transparency. And that happens today a lot with the JOCs, where they're engaged and especially if they're at risk,
Right.
they're using JOCs to have that dialogue. So,
What's harder? I mean, changing incentives or changing culture?
Culture, culture is definitely a lift in a lot of organizations, especially when you're an organization that's done acquisitions, or if you're an organization in a rural area, you're somewhat confined by the resources that are available. Uh, Large organizations, they make an acquisitions, and then you have a group here and a group here that were different uh, acquisitions, and they don't necessarily have the same alignment.
Hmm. Hmm. I want to shift gears a little bit just because I'm curious about, you having sat in the seat, how decisions actually get made, inside of a health plan. Not, from the org chart version, but the real version. Like walk me through that. Walk me through how these decisions, typically get made. Is it, committees? Is it, individual? Like what does that look like?
We have quality committees, clinical committees, medical economic committees, out of network committees, prior auth, monthly operations meetings. So health plans have a series of committees, and depending on the health plan, you could be a provider-led entity and you have a board to report into. And in some states, you need to have members of the community and a board in that health plan locally. Medicaid has some states that do that too. And
Hmm.
so always reviewing the denials. Are they appropriate? Did they make sense? And the health plan gets audited. So you have a compliance arena that makes sure we handle the audits that come in, and they do an ad hoc review of some ends. The plan president is over it along with the chief medical officer and operations and network, and they report into the plan president. But a lot of that is structured with policy because of regulatory requirements when you get a license to have certain functions in place in a health plan, and you have to submit your process, your model of care, your grievance and appeal process, and that gets reviewed by the regulators, and sometimes on a annual basis, and sometimes CMS audits you on different, depending on your products that you have there. So the decisions at the end of the day, if it's not a provider led, is usually the plan president who reports into a regional president, who then reports into a president for large plans. For
Right.
state-based plans, it's a little bit different, where they may have a governing board, a community plan may have a board. Well, they'll present monthly the quality metrics, the P&L, the MLR, the enrollment, any kind of clinical programs, the value-based payments. Those are all presented up through committee every month to make sure we're tracking. They usually set their baseline and goals every year. And when they deviate from the goals, you usually deploy a tiger team or a team
Right.
to be able to go and address those challenge areas. But they are focused and they are running, focus and managing to an MLR and an admin load aggressively. And they need to. If they're not, you need to, because,
It's interesting that you mentioned just around like the myth that like, health plans are just printing money. And you're like, no, that's actually not always true. So that's fascinating to hear this. The other thing that I started thinking about is, just innovation. There's no shortage of talent. There's no shortage of really smart people. There's probably no shortage of really good ideas. How how does innovation actually work, inside of larger organizations in the sense that if you can only do one or two things, how do things actually move along? I mean, you talked about how decisions are made. Do you feel like there's a pressing matter where, there's this arms race around sort of AI? I mean, is innovation now being forced in a sense where it's like, hey, we kind of have to do this? Like you mentioned, there's systems that are 10, 15 years old. Like we're running on a chassis that probably really needs to be redone here. Talk to me about that because I'm wondering if there's even more noise about innovators from the outside trying to come in, or do they try to sort of trust the group, trust the talent, and say, hey, we can kind of innovate internally, as opposed to having to rely on some of these external resources? When do they rely on internal? When do they rely on external?
very few organizations have the internal capability to deploy new technology or capabilities as new technologies because they're just running daily operations.
Yeah.
Uh, and that skill set isn't there. And if it's not budgeted, it's very difficult to get inside any system really because you're deviating from the budget and you need a good ROI in order to do that. Um, if you're solving a regulatory problem, that's different, and so that's handled a little bit differently in payers. But if there's a problem you're solving for, a specific problem, meaning you're not meeting the HCC demand, or your contracts are not paying as you should be paying,
Hmm.
right? When you're solving a problem, it's easier to apply a technology solution.
Mm.
Uh, there are still payers out there that manually adjust everything instead of doing bulk adjustments for 10,000 claims. That's going on, and you can have AI to reduce the administrative drain on what you're doing and save a lot of money.
Hmm.
Um, so you're going to be more effective if you're trying to engage a payer, if you're solving a problem. It's very easy to know if there's a problem because if you're Medicaid, your caps are public. And so you know which payers are struggling, and your solution might be able to be a solution for that. That's where there's exceptions that are made because this solution is going to fix this problem. The problem is which solution do I get? Because there could be four or five different solutions, all of which do a great sales delivery, but which ones actually work?
Right.
Uh, if you can somehow get a hold of a non-conflicted entity to do an assessment or a of which solution is right for you, would be the best idea and the best approach, because all delivery systems in all communities are different, and everybody's trying to sell to insurance companies and health systems, but they've been plummeted with vaporware that didn't work or didn't solve the problem or it was a good tool. It reminds me at Sutter Health. Well, I shouldn't say the name. Maybe you can delete that. There was a health system that I was working with. He had $3 million worth of software on the shelf that nobody knew how to use. A vendor came in and sold it, and they never used it. So they're very hesitant to engage with vendors unless it's solving a problem and they have a high confidence going to deliver, because that person that reaches out, if it's the CFO, CMO, director of IT, or director, their job is, or their credibility is at stake, bringing in a third
Right.
party to be able to do.
Right.
So that confidence needs to be there. That's why they usually go out to three vendors and they get presented and they select somebody. But
So then if you could fix maybe one structural issue tomorrow, what would create, maybe the biggest downstream impact?
population health management, it has different definitions for a lot of different payers and a lot of health systems. And so that administrative confusion at the provider level is very
Mm.
confusing. They have a go to this portal, go to that portal. This is the billing requirement. This is the PAL. Oh, this is the credentialing problem. We put a lot of unnecessary, every payer has its own intellectual property and they believe they do respective processes really well, and they probably do.
Right.
But what happens to the delivery system in primary care is they get inundated with sometimes 32 different portals that they have to go through to get an authorization in order to get a basic service. And so there's a lot of load that's put on a provider because the insurance companies are regulated to be able to do X, Y, and Z. And if we could somehow figure that out, and some of them have, there's centralized credentialing in some states. We need more multi-payer type products that we're not afraid of poaching members and not afraid of infringing on other payers or
Mm.
other providers, or somebody's poaching my members, or maybe they're offloading their high risk on me. But if we could get AI or tools that do administrative simplification on some of the basics, I think the providers could do more. We want providers to do more with less because there's not a lot of primary care providers coming in. And if we can get some level of administrative simplification through credentialing, value-based payments, maybe the model of care, the grievance and appeal, I
Right.
mean, we each payer did their own process, and they probably shouldn't have. We should have some type of consistency to reduce that or be cognizant of the administrative load, that we're pushing onto health systems.
All right, I'd be remiss if I didn't ask, but like, tell us, how can people follow the work that you're doing? Where can they sort of engage? Give us a sense of that, so that we make sure we you give the audience a little bit of that.
Well, we're on LinkedIn and we have a page on advisors on LinkedIn and also we have a website at onadvisorsllc.com. Just drop us a note. We're going to try to, over the next couple of years, be more engaged in the market. We have a team of retired experts that uh, have 25 years experience that can help you cut to the chase sooner than later.
Mm.
We typically get engaged to be able to assess and make recommendations, and sometimes we're the ones that do it, or sometimes we say, hey, you really need this organization or you really need this solution in order to execute on it. We'd love to be that partner for you, but we understand a business is a business, and we can definitely tell you whether or not it's a good idea or a bad idea to take risk. And we've done that before, and we've done those board presentations and broke the news. You're a great organization, but you can't do risk. So those are difficult discussions, but ones that you have to do. You have to know when to cut and run and when to double down and go. So
And I guess if you could leave sort of our community, the HI community, with just sort of a parting idea, sentence, what would that be?
healthcare is local. What's good for you may not be good for others. And it's a complex environment, and it's not as simple as people tend to think it is. It's very complex. There's a lot of influencers into the ecosystem of care. If you push on one stream, something's got to give. There's only so much money in the system, and when you push on one element, yeah, it's something else is going to push. So
Mm. I guess if there's one thing that I'm taking away from this conversation is that just because you read a headline doesn't necessarily mean that it's always true. I think if there's one thing that we take really serious, with the community is allow both sides to have a voice and to sort of share. So it's been really wonderful to have an insider come in to share, a different perspective, and just appreciate you being able to be as candid as you were, and sharing, and obviously doing it in a very respectful and meaningful way. So if you're listening to this and you found this particular conversation to be helpful, would you mind sharing it, engaging in it, letting us know what you felt was important? If there is a topic that you want us to explore, or even a leader that you'd like to hear from, drop me a note, or leave a comment. This platform, it is absolutely about community, and being interactive. And we can only innovate when we are in this type of a community. So thanks for listening. Keep building with purpose, and we'll see you next time on the Advancing Healthcare Innovation Show. Thanks, Mike.
thank you. Appreciate it.